Okay. Thank you all so much for joining us for this month's Miami Global Brain Tumor Symposium. We really have an outstanding symposium today. Just a short introduction before we get to the speakers tonight. My name is Michael Ivan. I'm one of the brain tumor surgeons here at the University of Miami and director of our research program. I'm joined tonight by my co-directors, Dr. Morcos, who's the professor and co-chairman of our department, and also director of our cerebrovascular and skull-based program, and Dr. Komatar, who's professor, our residency program director, and director of the UMBTI. I'm also joined by Dr. Benjamin, assistant professor, director of our skull-based lab, and a brain tumor specialist here at the University of Miami. This is our 35th session of these symposiums. They've all been outstanding, and we couldn't do it without the extraordinary help from our administration, from both the Sylvester Cancer Center, University of Miami, and the Department of Neurosurgery. And these are the people that really make it happen every week and every month, and we thank them so much for their time and help behind the scenes. If anybody wants to learn more about our symposiums or about our department, you could always find us on the web. Here's our departmental website. All these videos get posted to YouTube and are there for you to enjoy after the sessions. If you want to learn more, we're also active on social media, Twitter and Instagram, and you can find our links here. As you know, the Brain Tumor Symposium is only one of the symposiums that we have here at Miami. We also have a Pediatric Neurosurgery Symposium, which is monthly. The next symposium will be on April 12th. We're having Dr. Rudka, Dr. Abraham talking about epilepsy techniques and how they've evolved over the years. And also our Cerebrovascular and Skull-based Symposium is the third Thursday of the month. And this month will be extraordinary without exception, talking about vascular skills of visualization and robotics with some outstanding speakers. So be sure to tune into those as well. And a short teaser for next month here on the Brain Tumor Symposium, we'll be having actually a joint symposium with the Skull-based Society, with the Surgeon's Log, who is directed by Dr. Walter Jean and Michael Huang. We'll be talking about glomus, jugular foramen tumors, and kind of tackling them from different aspects, from either surgery, radiosurgery, or an ENT. And we'll be having one of our fellows kind of talk about one of the cases in detail. So it's sure to be an exciting symposium. Be sure to tune in on May 5th. For housekeeping, please use the Q&A button. We try to make this as interactive as possible. We don't offer CME for this, but you will get an email documenting your participation. And please be sure to like, follow, and share our videos so they continue to grow, and we can really distribute this amazing information from some of the best in the world that we get every symposium. This week, we have a great group of panelists. Dr. Zachariah, who's been on here before, associate professor and co-director of the neuro-oncology program at Penn State. He's also director of the brain tumor and skull-based program. Dr. Hanf, who is an assistant professor and specialist in minimally invasive surgery and chief of neurosurgical oncology at Westchester at New York Medical College. And Dr. McGill, one of my co-residents, who's now a fellow at Ohio State with Dr. Prevodello, who just got accepted to be assistant professor at Northwestern starting in just a few months. So congratulations, Stephen, on your starting your career in the Midwest. This week we have just an extraordinary speaker. If anybody should be giving this talk, this is the one you want to listen to on Cushing's and pituitary surgery. Dr. Laws doesn't really need introduction, but because he's probably one of the most recognized neurosurgeons in the world. But he is the director of the Pituitary Center and Neuroendocrine Center at Brigham and Williams Department of Neurosurgery, as well as a professor at Harvard Medical School. Dr. Laws had his undergrad at Princeton, and then he went to Johns Hopkins, where he got his medical degree as well as his neurosurgical training. He took 2 years off while he was there to also work at the CDC and devote some time and research to public health. He's been an active faculty member of some of the best neurosurgery programs in the country, including Johns Hopkins, Mayo Clinic, George Washington, UVA, and now at the Brigham, and has really contributed in each one of those departments extraordinarily in developing their pituitary programs. He's obviously had a major impact on organized neurosurgery. As you can see here, the list of his presidencies in World Federation, Congress of Neurosurgical Surgery, AANS, Pituitary Society, and one of the few neurosurgeons to also be president of the American College of Surgeons. He also became a member of the Institute of Medicine in 2004. He's literally written the book on pituitary surgery for the last 30 years, and you can see here just a few of his books, just a few of 22 textbooks, most of them on pituitary surgery, over 500 manuscripts, also written on brain tumors, and he's just, his contributions to this field have been, we could go on for hours about it. He still remains extremely active surgically, performing over 6,000 pituitary surgeries in his career, probably more by now. I think that number is outdated. And we're just so excited to have him here talking about pituitary surgery and Cushing's, and we thank him for his time. Dr. Lawless, thank you so much for joining us this week.
Oh, thank you, Michael. I am really delighted to be part of this massive educational effort that is so good. And I'm really privileged to be part of it. And thank you for that invitation. So we're going to talk about what I think is one of the most difficult things, along with craniopharyngioma, what we do in cranial neurosurgery, and that's Cushing's disease. And I'll start you with a little bit of the history. I have no disclosures. And this is my favorite picture of Harvey Cushing in his 30s. He started his work at the Brigham in 1913, and he had written this book, which I showed to all of the medical students. This book was published in 1910. I'm sorry, 1912. It was, his lecture was in 1910, and it was published in 1912. 47 patients with pituitary disease that he studied in his inimitable, compulsive way to really try to understand things. And most of the basic principles of what we know about the pituitary and how it works are there in that book. And I tell the medical students, you could do this. You could look at your patients and derive something wonderful from it. One of the people in that book was Minnie G, and we kind of researched her course. You can see, I believe, that she has all of the clinical manifestations that you want to see in Cushing's disease. He categorized her differently as someone with a polyglandular syndrome. The curious thing is that he saw her in 1910, and she died at the age of 53, never having had surgery. Spectacular story, really. So I need to advance my slides here. His original interest in the pituitary was with these pluriglandular syndromes, and he was interested in strange people who had bearded ladies and biliary and suprarenal virilism and pinealism and genito-suprarenal syndromes. And these were the things he talked about in the book, and wondered whether these symptoms were attributable to a disordered pituitary or one of the other glands causing hormonal dysfunction. So if you look at group 5 here, this is what he ended up categorizing Minnie G as: a case with a polyglandular syndrome in which the functional disturbances on the part of the hypophysis are merely one and not a predominant feature of a general involvement of the ductless glands. So he was on the trail. And in England, there was a fellow named Bishop, who was a professor at Guy's Hospital, and he saw Cushing's monograph of 1932 with a series of patients who had what we call Cushing's disease now, and he said, we should call this Cushing's disease. And this is the paper that coined the name by Dr. Bishop. And he was enamored with Cushing's work. Here's the bulletin of the Hopkins Hospital in 1932, where he published a series of patients that had all of the symptoms of Cushing's disease. And Bishop said, from a consideration of these cases that Cushing published, we propose to refer this condition to Cushing's syndrome. So that's how it was named. Pretty interesting historically. He had been working in the Hunterian laboratory at Johns Hopkins under Dr. Halstead, and noticed that in the lab, looking at some of the specimens of tumors, not particularly Cushing's disease, but he saw basophilic cells, which he thought could possibly elaborate some other essential secretion. So he had a real insight into many of these things. These are some of the patients that were in his monograph, and they all fit the bill for Cushing's disease. And they all had different names by their doctors and the people who worked on them. There were quite a few that were in Eastern Europe, and a doctor named Nikolai Itsenko was very much enamored by this problem, and it was called Itsenko's disease in that part of the world ever since he published in 1924 cases of what we would call Cushing's disease. And here, this is another one from 1924 in a male, which you can get them as well as others. Parks Weber is a British person who noted some of these cardinal symptoms of Cushing's, purpura, high blood pressure, amenorrhea, obesity. And he, in patients who didn't have an adrenal tumor, and look at the journal, the British Journal of Dermatology and Syphilology in 1926. And here's Parks Weber's case, and such a nice example of a pseudo-encapsulated basophilic adenoma. And this was the histology showing that these were basophils in here within the gland. Here's the anterior lobe, the posterior pituitary, the stalk up here. So they, again, were zeroing in on this thing. And Cushing wrote a letter to one of his pupils, Sir Geoffrey Jefferson, who was in Manchester, England, saying he vented himself on this subject before the Harvey Cushing Society. And he said, someone will eventually suck out the small adenoma, which is usually visible in the pars anterior and causes this illness. One of his students who was at the Brigham in 1924 went back to Scotland, and he was the only one who kept doing the transfunoidal approach after Cushing abandoned it in 1927, 1928. But here is Dot's Scottish insights about Cushing, and his scientific approach was to imagine a theory and then bend every effort to prove it. And he and Dandy, as you may know, had a little conquest over that. And it's a tribute to his wisdom that this dangerous approach usually led him to the truth. So it's kind of fun. Now, this is one of my first patients with Cushing's disease when I was at the Mayo Clinic. And as you can see, she has cardinal symptoms of the disease. She has the centripetal obesity or pot belly. She has the violaceous striae. She has them in her arms and legs. She has enlarged supraclavicular fat pads. She had a buffalo hump, and you'll see moon facies, hirsutism, and weakness in the arms and legs. All symptoms that we see pretty regularly in Cushing's. I did a lot of pediatric neurosurgery too, and here in Minnesota, this is a set of twins, and these are their school pictures done every year to age 13, when you can see Ron here, who first showed the manifestations of Cushing's about here, developing the disease, and look at his identical twin brother. This is a horrible disease in children. It causes growth disorders. It causes terrible psychological problems. The kids get bullied, and it's really damaging to their ego and their development. And getting a cure out of a Cushing's kid is a real triumph. Here's the approach you all know. Now, this is the transeptal, transfunoidal approach to the pituitary. And I was lucky enough to get in on the ground floor of this in the late 1960s, and had used the microscopic approach for many years until the early 2000s when I met Paolo Capobianca and got converted to the endoscope. The incidence of Cushing's disease is around 16% of our series of pituitary tumors. And this is when we had 4,300 cases. And the 16% is held pretty steady over the time. And here's the differentiation of the different types of pituitary tumors that we have operated on, all transfunoidally and now all with the endoscope. One thing about Cushing's syndrome is it's not always Cushing's disease. And if you're a gambler, you say a patient who looks Cushingnoid from Cushing's syndrome has Cushing disease, you're 80% right, based on our analysis of patients, 100 cases at the Mayo. And 10 were adrenal adenomas, 7 were adrenal carcinomas, and somewhere between 5 and 10 were different ectopic sources, including carcinoids, bronchogenic cancers, one CRH adenoma, really strange cases, but they do occur. And you don't want to operate on the pituitary if it's not there. Here's the this physiology that you all know about how cortisol is regulated, with CRH coming from the hypothalamus, stimulating the pituitary gland to make ACTH, which stimulates the adrenal glands to make cortisol. There's a positive release from CRH, and there's negative feedback from cortisol in the general circulation. So we take advantage of these stimulatory and inhibitory factors in doing the biochemistry of the diagnosis of Cushing's disease. And it's really a nice puzzle that you can work out most of the time by following these trails. So what do we do when we see a patient we think clinically has Cushing's disease? Most important, I think, is to assess the extent of disease carefully. Obviously, taking a good history, learning about the patient as a person, and looking at the pace and severity of the disease, the nature and symptoms, nature of the symptoms and signs, the terrible comorbidities, mainly hypertension and diabetes mellitus, and the completeness and consistency of the laboratory tests that have been done, which are really a crapshoot because so many of them are not really reliable or all the time. And you can make a lot of mistakes without the thorough laboratory analysis. And now, of course, a thorough and careful imaging analysis. Imagine doing these before we had anything besides tomograms. We had CT scans, and then finally we had MRI scans, and it was a real pleasure to see that. So one of the things I preach is to make sure that the diagnosis is secure before you take that patient to the operating room. And here's the urinary free cortisol that we depend on more than anything, really. But look at all the things that this disease does to people. Many of them have psychosis. There's clearly brain effects. They lose their jobs. They have trouble with their partners. Some of them are psychotic. They have hypertension. That sometimes we'll see patients with 4 different antihypertensive with Cushing's disease. You saw the central obesity and the striae, the thinning of the skin with easy bruising, excessive bleeding, the bruising here, the osteoporosis that it leads sometimes to fractures, the susceptibility to infections of all kinds, including wound infections. And ulcers, not so much a problem anymore, but the acne is really important. And many patients will ultimately develop, after having hair on their face and on their body, they'll be losing the hair from their head. And it's a real common sign of Cushing's disease. Then you have to make the endocrine diagnosis. You have to show that there are elevated corticosteroids, and we show it also with loss of diurnal variation by doing fasting morning cortisols and late midnight salivary cortisols. These help very, very much. And the 24-hour urinary free cortisol gives you a snapshot of the whole day's exposure to cortisol for some of these patients. And for me, that's the most important thing. I learned this from Martin Reinke in Munich. And he said Cushing's disease is so terrible because every day that patient has elevated cortisol is damaging their body and their mind sometimes. And that's true. And then we look for elevated ACTH, which is often but not always present. The dexamethasone suppression test, again, uses some of that inhibitory problem that I showed you about. And it's okay, but not perfect. And Petrosal sinus sampling, you must remember, doesn't make the diagnosis of Cushing's disease. You have to have a patient with Cushing's disease to do inferior petrosal sinus sampling because it tells you whether it's from the pituitary or whether it's from some other place in the body. So we do very few petrosal samples, but they're helpful when they're there. Here's what they look like. This is a venogram. You can see the cavernous sinuses, the intercavernous sinus. These are the inferior petrosal veins. They've been catheterized, and we check the ACTH levels after stimulation with CRH in the periphery to make sure there's nothing coming from the vena cava, and then from the right and left petrosal veins. And as you can see in this one, the left was really high, and it helps in about 60 to 70% of cases to localize the site of an intracellular tumor if they fit all the other characteristics of Cushing's disease. The imaging analysis now is pituitary MRI. We have different sequences. We do sometimes dynamic scanning to watch the tumor blush with dye and then lose it. We worry about an ectopic source. We'll do abdominal or adrenal CTs and MRIs and a pulmonary CT. And there are a series of PET scans with 2-deoxyglucose, octreotide, and dotatate, but none of them is really seriously precise enough to make the diagnosis. It helps in some cases. Here's the typical case with an MRI showing the ACTH secreting tumor compressing the normal gland, extending to bulge up toward the chiasm. Here's the ACTH stain, and here's the H&E stain. And all these dark cells are secreting ACTH. Here's a patient, a 19-year-old daughter of one of my colleagues at GW, and she didn't have a lot in the way of symptoms, but we looked at this scan. This is just an MRI. It was called normal by the radiologist. Haha, look at that. There's the tumor. She had a perfectly encapsulated intracellular microadenoma and has done well ever since. Now, one of the other things that came to light and is a real thing is the association of Cushing's disease with cerebral atrophy and also with cognitive and emotional defects. Here's a case. Now, a patient in her 30s and has this brain with a tremendous atrophy of the whole cortical surface. And interesting that she doesn't have much subcortical atrophy, but sometimes they'll have both. And here's where we do go once we've made the diagnosis. This is Dan Prevedello, by the way, when he was my fellow. And this is Kojo Hamilton. And this just shows the concept of a three-handed approach. This doctor, this surgeon, can use two-handed microdissection through the two nostrils. And this surgeon is steering the endoscope and showing the visualization that you need to have in order to do the proper job. So it changed my life to move to endoscopy. This is Capabianca stuff as well. Here's the cellar floor. Here's the planum sphenoidale if you're going transtubercular. Here's the clivus. Here's the carotid protuberance. And we didn't see this with the microscopic approach. Here you see the optic canal and the opticocarotid recess. So with this view of the anatomy, here, this is the vomer down here for the midline. With this view of the anatomy, the complications of damage to the carotid and getting misguided have really essentially vanished. This little close-up of the OCR. So here's how I do it. So I don't usually do how I do it, but some people ask. I do a wide exposure of the dura from one cavernous sinus to the other, from the floor of the sella to the tuberculum. When I have the dura exposed, I'll either make an X or do a cruciate incision, depending on what the intercavernous sinuses look like. Once the incision is made, and we'll show you a little bit of this, I make a careful and complete subdural dissection. While you're doing the dissection below the dura, you can sometimes feel softening where the tumor is located, or even firm areas where the tumor is firm and fibrous. So if the tumor doesn't appear with that initial dissection, we incise the gland, and then I repeat the subdural dissection with pressure laterally in particular and inferiorly in particular to try to force the tumor to show itself. And if we find it, we do extracapsular dissection if possible, as we internally explore within the gland. Now, we know from other studies that the geography of different types of pituitary cells in the pituitary is well known. And most of the corticotropes are in the anterior medial wedge right up to the pars intermedia. So if I don't find anything else, I'm pretty sure the patient has pituitary Cushing's, I will excise the medial wedge all the way back to the pars intermedia, and then probably also excise the pars intermedia, because there are some Cushing's tumors that lodge themselves there. If that doesn't work, I'll get external to the lateral aspect of the lateral lobes and with a Hardy dissector primarily, and mobilize them and put them in the middle of the field. And then we'll explore and excise the posterior lobe if necessary, go all the way back if we haven't found anything, and make sure it isn't in the posterior pituitary. It almost never is, but it can happen. We carefully explore the top part of the normal gland. I try to leave a residue of normal gland against the diaphragm, and therefore not open the diaphragmatic aperture, not get a CSF leak, and not damage the pituitary stalk. If the stalk is a problem and you have to cut it, and getting the approach through the endoscope, especially if you're doing a wide approach and getting into the cranial portion, if you have to cut the stalk, do it sharply with a knife. Do not tug on it. Do not compress it, because if you damage the axons in the cells that make up the body of the stalk, you'll get karyarexis, and the cell bodies will die and they won't recover. If you cut it sharply, they have at least a chance of recovering if the axon doesn't transmit the death to the cell body. So we try to avoid a CSF leak if possible, and that's one of the things that I try to do. If we don't do that, we use a fat graft to stop the CSF leak. So here is a video showing the exposure now of a tumor. This is a Cushing's patient. You can see the MRI, how the entire cellar floor was just eroded away completely by the pressure of this tumor. We're looking with the Doppler here, making sure the carotids are not in jeopardy, making an initial vertical incision, and now starting the subdural dissection. This is how I do it. One side and then the other, just staying in the plane below the dura, and get through both leaves of the dura, by the way. So here's the tumor. Now it wants to come out. So you see it emerging. This is a very typical Cushing's adenoma, and it's suckable in many parts. It did not have a capsule, so we didn't even think about an extracapsular insection of this one, but it did extend into the cavernous sinus. And you're beginning to see the cavernous sinus right here. And we employed a 30-degree lens on our endoscope and are looking this way to take out the part of the tumor that was compressing the left optic nerve as it went into the chiasm. Now, so here's the cavernous sinus wall. And remember, there are leaves of dura. They're tough, and they protect the cranial nerves. Here's gel foam extending into the cavernous sinus portion and into the rest of the sella as the closure. So now here's that patient you saw before, one of my very first. This is, believe it or not, 3 months later. This does not always happen. You can't see the extracapsular tumor up here. It's behind my sign that says screen sharing. I don't think I can move it. Yeah, there it is. Anyhow, no, sorry. Okay. At any rate, it takes more than 3 months for most people to find themselves again. And it's so encouraging for the surgeon to hear a patient tell you that she's herself again after sometimes years of misery. So our outcomes are pretty good, relieving mass effect, normalizing ACTH up to 91%, depending on the size of the tumor, preserving normal function most of the time. Recurrences are terrible. They're 12% within 10 years, 20%, 25% within 20 years. But this measure, living in well 10 years, was 75% in our series. And the remission rates you see here are 81% in primary micros, redoing patients done elsewhere, 61%, not always macros, about 61%. They usually are invasive and hard to cure. And the recurrence, as I mentioned, are common. Operative mortality was rare. The one patient that died was an elderly lady, very frail and very sick. She got SIADH, was transferred home to a rural hospital where they corrected her too soon, and she died of central pontine myelinolysis, which happens when you correct SIADH too soon. We had 6 patients who had permanent diabetes insipidus out of that. Transient SIADH occurred. CSF leaks occurred. Now, this was interesting. I only saw 2 cases of pseudotumor develop after an operation for Cushing's disease, but it's happened. And the patients had terrible headache, brain swelling, and fortunately, it was transient. And then we've had 1 each of bleeding disasters, optic neuropathy, and we had several DVTs, and we do standard DVT prophylaxis with our patients. We don't use any perioperative routine steroids. We completely explore the cell and the gland. We consider re-exploration if you don't have a fall in blood cortisols initially. But we'll usually follow these patients out, and many of them will be benefited by a re-exploration, but you have to do it all over again with the diagnostic procedures. And we used DVT prophylaxis. I give them 81 milligrams of aspirin at night 4 or 6 weeks. And we've been lucky with deterring DVTs. Now, some people may still do intraoperative frozen sections and measuring ACTH during the operation. These measurements I have found to be useless. The pathologist really can't figure it out because the normal tissue and the tumor look so similar, and the ACTH measurements are useless because of the timing that's necessary till you get them back. So we carefully explore the dura for invasive ectopic and ectopic tumor and go back and look at the scan in detail to make sure there's no small tumor in the cavernous sinus or in the infundibulum that may be the problem. So here are the problems. Tumors not found. Why? Ectopic source. Is it hyperplasia? Now we have a number of patients with hyperplasia rather than tumor. And you have some patients with multiple adenomas where you only take out one of them. We sometimes incompletely take out the tumor, and especially the cases that have invasion. We rarely do a hypophysectomy, but if a patient is very ill, it's probably better to do a hypophysectomy and replete them with their hormones than to have them suffer continuing symptoms of Cushing's disease. We do have hypopituitarism after surgery sometimes, but it's readily correctable in most patients. A small cella is a real problem with the surgical aspects of it. Our instruments have to be modified to deal with that. Now, this is from Ed Oldfield. This is a ectopic tumor that was in the stalk, just adjacent to the stalk. And here's an extended approach. So the planum has been taken away. The tuberculum has been taken away. The cellar floor has been taken away. The pituitary gland has been explored and mobilized, no tumor. And here's the tumor. And so with the exposure that is available using this extended approach, you can see the infundibulum. And this is his technique using little pieces of gel foam to do the dissection. You can do an extracapsular dissection of some of these, or even not. Just getting them out of there is doable. But you have to realize it's an ectopic tumor, and you have to be able to get at it using an extended microsurgical approach. What are the alternatives when surgery is not curative? Well, surgical reexploration I talked about. We do that if it depends on how sick is the patient. There's a lot that goes with knowing the patient and how they are faring with this illness. We can do a hypophysectomy, as I mentioned. We have radiotherapy and radiosurgery. I'll talk a little bit more about Gamma knife, which has been my most common exposure to radiation in these tumors. We have used adrenalectomy. If you have to have a cure, you can do it with adrenalectomy, but you have the worry of Nelson syndrome. And you have medical therapy, cabergoline, pasireotide, mifepristone, Korlym, and nodrilostat. That's a handful. Each of them is wildly expensive, except cabergoline is pretty cheap now. Each of them has side effects or counter effects, like mifepristone raises the ACTH, and these are still not experimental, but they're still in clinical trial use. Here's the Gamma knife. I worked for 15 years at UVA with Laszlo Steiner and his successor, Jason Sheehan, who's is still there. And I was one of his bigger referral persons with patients we didn't cure. And he was able to target the pituitary and get a cure in many cases. And here's our initial evaluation of the first group with 74 patients. They were followed more than 12 months. Normal 24-hour UFC occurred in 73%, which was remarkable. But the time to remission was long. It was a mean of 16 months. So you had to cover them while you're waiting for the Gamma knife to kick in. And the other caveat is a new hormone deficiency can be as high as 40%. But again, we can replace most of the hormones that might be affected. So it's not as major a problem as you might think. So finally, here's our target. This is the pituitary tumor cell. You can see the receptors on the surface. You can see in the cytoplasm the manufacture of steroid hormones with all of the promoters and factors that allow this to occur. And here you have the nucleus with its reproductive capability to make some of these tumors very, very difficult for the patient as they recur, or very few, thankfully, turn malignant. anyhow, it remains a challenge. We haven't got all the answers. I think it's a fascinating subject. It's one that demands multi-divisional cooperation, and we learn a lot from the endocrinologists, and they learn something from us, and it's a mutual situation that we all enjoy. And I know that all of you who do Cushing's admire the challenge and hopefully do really well with it. Thanks very much.
Thank you, Dr. Laws. That was outstanding, and what a great review from in all aspects of Cushing. I had a couple questions. One was, at the end of your resection, what are your check boxes to kind of minimize that chance of you leaving a small recurrence? Do you do, other than getting hemostasis, do you do any kind of special washing with either alcohol, or do you just use the endoscope really closely to kind of look at that, or anything specific?
Yeah, I gave up alcohol very early in my career when it was thought to be helpful in acromegaly, and all it did was damage the rest of the gland or get into the CSF and cause real mischief. So we stopped that right away. I think I had 2 cases where we tried alcohol. What I do is what I learned. Another thing I learned in Italy was the spaghetti procedure. And you take a cottonoid patty that is about the size of half the cella, and you put it on the end of your instrument and you twirl it around, basically scraping the interface between the tumor and what you think is the normal gland. So I do that in most cases. Sometimes we'll go with a number 6 sucker very carefully along the margin between the tumor and the normal gland. And that's pretty much it. We do get a very good look at it. We use the endoscope right in there, and I look at the dura very closely to see if there's dural invasion. You can usually tell. In that case, sometimes we'll do some cauterization. It's not anything I do a lot of, but it's something to think about. If you do a craniotomy and you see it sitting there in the dura and you can't resect the dura, we cauterize it. So you can do the same thing in the cella, but it's a little trickier.
And then the other question I had was upon recurrence. I've had a couple cases that have had outside resections, and then 2 or 3 years later they come back and they have evidence of both cortisol and also their clinical symptoms, and they could just tell you that they have Cushing's now. It's amazing how they can
remarkable, isn't it? They tell you before you can measure it, right?
And in most of those cases, the MRIs were not very helpful. And,
right.
I've had like 3 of them recently where I've decided just to go in to take another look because it was found on the first surgery that it was there. But what is your threshold to kind of, if you know that it was from the pituitary gland and it recurs, do you have a low threshold for doing another surgery, or what's kind of, obviously if it's not spread into the cavernous sinus or something where it's not resectable, but.
Right. Well, most of all, it depends on the patient and how sick they are, in my opinion, and how important is it for that patient if you can do the job. So you have to think all the way from a radical thing like the hypophysectomy, which probably will produce DI, which is very unpleasant and isn't always reversible. Then you go to what I call is an extensive exploration and removal of anything that looks suspicious. And again, is it worth it to the patient? And I think, like I say, like Ranka says, every day that patient is going to live after you're done with them, that they're still exposed to too much cortisone is a disaster for them. So I think doing a radical subtotal resection is a reasonable thing to do. That's generally been my what I do. When we especially patients done up elsewhere, or patients I've done and come back. I'm having one of those in clinic tomorrow. It depends on how sick they are. And I didn't do the part in this lecture about wannabe Cushing's and about cyclical Cushing's. There are hordes of disturbed people out there whose lives they think will be changed if they could only have their Cushing's disease taken care of, and they don't have it. And there are endocrinologists around who send patients for that. You get beaten down by some of these patients. They're so insistent that they have Cushing's, and they lie to you about their symptoms. and then you have the cyclical ones, and I've seen maybe a couple or three truly cyclical Cushing's patients, but they're hen's teeth. They are few and far between. And again, you have to think about the patient, and if you can get rid of the cortisol, if there is constant excess cortisol.
Great. Any other questions from our team here before we get to the cases? Okay, Brad, do you want to start with your case first?
Sure, certainly. Yeah, thank you, Dr. Laws. That was a great kind of deep dive into Cushing's. I've learned a lot from reading a lot of your work, and I found these. I've been out, I don't know, 6 years now from fellowship, and these are some of the most difficult cases. I feel like I've made actually the most progression since that time in these cases. I just think there's so much nuance, as you discussed, in terms of just the diagnosis and really doing these cases, some of the more difficult kind of, I think, neurosurgical cases.
Yeah, they really are.
And
so hard. And you really don't know how far to go sometimes.
And I think, as with many things, experience is key, and you have obviously just such a tremendous kind of depth and breadth of experience, and it's hard with relatively rare pathology to get that. And I think that's why sessions like this are so important, and we appreciate you sharing your knowledge and experience with us. So this is not the craziest kind of case from a presentation standpoint, but a couple maybe interesting points from here. So this is a 50-year-old woman who had presented to the ER with abdominal pain, found to have an umbilical hernia, but was hypertensive and previously hadn't been. And for some reason, somebody decided to get a urinary cortisol that was slightly elevated. And I think that's a little different. I think, as I'm sure you've seen in your career, a lot of these patients have a really long prodrome, where when you see some of the stark pictures that you showed, it's very obvious to anybody who went to medical school that that patient has Cushing's, but a lot of times it's more subtle than that and slow, and they see one doctor and they have hypertension, and somebody else and they develop something else. And it's only when they see the right person where they put it all together.
Right.
She had some other symptoms, including recent weight gain and kind of some mild prediabetes, but not felt to have typical Cushing signs and symptoms when she was initially evaluated by endocrinology. I don't think they were convinced she truly had Cushing syndrome just based off the constellation of findings. So she had repeat elevated 24-hour urinary cortisol, which I think you alluded to as being kind of one of the more important things. She was a night shift worker, which kind of adds to the complexity, right? If you're checking AM cortisols or you're looking for this diurnal variation, it's going to throw your analysis off. This is something I hadn't really thought about, but when the endocrinologists evaluate patients like this, they try to time their testing in line with how these people work. And so she had a dex suppression test and salivary cortisol, but was basically lost to follow-up for some time. And then initially had a 1 milligram suppression test, didn't suppress, continued elevated cortisol, salivary cortisol is elevated, and suppressed with the high dose dex suppression. So really everything pointing to a pituitary source. Imaging, again, concerning for pituitary origin, as you mentioned, oftentimes read as unremarkable. I'll show you some static images on the next film. But there were two suspicious areas when you looked at the SPGR and on T2, where kind of a small focus of hypointensity off to the right side of the gland, and then something eccentric to the left that
Right.
maybe looked a little bit more convincing, I think, as an adenoma. So she was scheduled for surgery, but then it presented with shortness of breath and actually had a lung mass. And we know there's a very, very strong association of Cushing syndrome with small cell and neuroendocrine tumors.
Right.
But she had non-small cell adenocarcinoma of the lung, which I think is just unrelated but unfortunate. I think because of the diagnosis of lung cancer, the endocrinologist really wanted to be sure. So she did have an inferior petrosal sinus sampling, which again, demonstrated a ratio that is consistent with a central pituitary source. Seemed to localize eccentric to the left, but I know you also touched on the fact that that's only maybe 60-70%. So despite the diagnosis of lung cancer, she was felt to be stable, and after kind of a multidisciplinary discussion, everybody felt it important to proceed. So the surgical approach is exactly as you had outlined, and these are again just some diagrams from Dr. Oldfield's manuscript, but a lot of these techniques are adapted from things that you and Dr. Oldfield had really developed, so is kind of the same. And so I'll just kind of just briefly go through this video, but the principles are no different, and I think a lot of the videos I'm sure you'll see from the panelists are very similar, only because we've learned these techniques from masters like yourself, but is really wide exposure, now exposing over the bilateral cavernous sinus, the Doppler to identify the cavernous carotids. You have a beautiful kind of view of all the anatomy here that is going to afford you wide exposure. So wide opening and now the subdural dissection that you mentioned to really see the surface of the gland, particularly when you're not absolutely convinced of where tumor might be. And so we're just doing kind of a stellate opening of the dura and widely exposing the surface, exploring the lateral side of the gland against the cavernous sinus, and then the superior and inferior aspect. And I did feel there was this subtle abnormality on the left side. It was a little yellowish. That corresponded to what I had felt to be the most likely location for the adenoma. And we start and try to do an extracapsular dissection, which I to this day find extraordinarily difficult. Make an initial incision. I actually ended up making an initial incision even further medial because I was obviously in the lesion here. So made another incision to try to stay extracapsular. And then, worked that plane and felt that there I saw a little bit of normal glandular tissue, and then was able to kind of stay somewhat extracapsular for a portion of the dissection, working superiorly now. And the plane maintained for a little bit and then broke down. And then ultimately was able to remove the bulk of the tumor en bloc, and then obviously in a piecemeal fashion remove the rest of it. You get a beautiful view, like you said, of the lateral wall or the medial wall of the cavernous sinus. You could remove some of that dura sharply and able to explore the plane between the gland and the lesion. But because of that small little area, this is with the 30-degree scope, exploring nearly an identical view to what you had showed. And this is just exploring that small little area that we had maybe seen on the imaging to make sure there wasn't a tandem additional adenoma, a kind of sequential incision through the depth of the gland back to the posterior gland. And then this is just a repair, basically with some gel foam and some Duragen and glue. So she did well initially after with low post-op day 1 and 2 cortisols, and remains on hydrocortisone to this day. She did have an interesting presentation about 6 to 8 months after, where she had some facial puffiness and edema. So that initially sparked some concern for recurrence. So she was taken off hydrocort, had a stim test, did not stim, and she subsequently had significant improvement in her diabetic control and weight loss, all consistent with good response. So she continues on hydrocortisone. That was felt to be unrelated, and she's being treated for adenocarcinoma, and then continues to do well. So a relatively straightforward case in a number of ways, but with some kind of little interesting tricks and things that could trip you up. But
anything fishy about the histology?
Nothing standard. ACTH, basophilic adenoma, low Ki67 of around 1%. Nothing unusual, but that's a great thought of this. Could this be something else?
Yeah, great, Brad. A little off topic, but Dr. Laws kind of talked about it in one slide. But with a cancer as well as Cushing's, the hypercoagulable state is extremely high in this patient. And so anything, I know Dr. Laws said he puts patients on aspirins immediately post-op as well as
day after.
Yeah. Anything you did differently in this patient for like that screen them or post-operatively?
Not really. We did that for a while. I don't even get the PTT and on them anymore. I've talked about this very little because I get ridiculed by medical doctors who say that 81 milligram aspirin is nothing and has no capability. Some of it may be, along with giving them the aspirin, they get the talk that they have to keep their legs moving and be active. And so, as I said, we've had just 2 DVTs, and I learned this from Fahlbusch in Germany. He published about this many years ago now, and some people use much more in the way of effective blood thinning, but again, I don't want anything to screw up our operation either. So yeah. I've been reluctant to go with any big guns.
Yeah, and I didn't mention this here, but it's funny you bring that up, Mike, because she was discharged home, I think, on postoperative day 2 or 3, but she represented a week or 2 later, really for diabetes control, but had an MRI at that time, which showed a couple punctate infarcts, asymptomatic, but interesting. And again, I think, like you said, this constellation of hypercoagulable states, that it's probably just a horrifically high risk of thrombotic complications. So it's interesting that you brought that
up. And then
up.
I guess that's happening with COVID too.
Yep.
Yep.
Yeah, well, great case, Brad. I mean, a great technique, and it looks like it was a great outcome considering a very challenging patient. So nice job.
Yeah, appreciate it. Thanks.
Simon?
Yeah, I'm sharing the screen now. Can you guys see that okay?
Yeah.
Great.
Yep, that's good. Thanks.
Thanks again for having me, Mike, and panelists and Dr. Laws. This is an endlessly fascinating subject, these patients with Cushing's disease. And the case I have here is a case I'm actively involved with, it was a recurrent case, and as we know, many of these do recur, and so getting your insight, Dr. Laws, and the panelists on this case, I think would be extremely valuable as I'm kind of wrestling with this, and it's all very recent. So starting with the presentation, is an 18-year-old male, and he had symptoms for about a year, maybe more, prior to ultimately presenting to a pediatric endocrinologist. So classic symptoms: significant weight gain, became very obese without any real dietary changes, noticed himself bruising very easily, also was incredibly fatigued, had significant issues with joint pain, was not able to participate in sports anymore at the high school level because of that pain. And he also was just, when being seen by his pediatrician, noticed to have elevated blood pressure, some elevated blood sugars, and that ultimately is what prompted the visit to the pediatric endocrinologist. He also noticed some issues with vision. He described it as difficulty focusing. And so the pediatric endocrinologist, astutely thought that this might be Cushing's, and then performed the workup here. Some of the specific numbers I have, and some of them I don't, but his 8 a.m. cortisol was off the charts, was in the 40s. His ACTH elevated, but not off the charts to the level of the cortisol. She then went ahead and got a 24-hour urinary cortisol, which I think was roughly 3 to 4 times the upper limit of normal. And he had 2 midnight salivary cortisols that were also very clearly elevated. At that point, she did not do a DEX suppression test. She was fairly convinced that this probably was a pituitary source. This is the MRI that he had in December of 2019. So pretty obvious one here, not the one where you have to kind of dig through dynamic imaging, et cetera. So 2 centimeters in its greatest dimension with some potential cavernous involvement. That's the middle sequence there that I put the white arrow on. It's maybe kind of posterior and kind of sneaking into the cavernous sinus a little bit on the right, though not clear. And he, because of the optic nerve, optic chiasm compression, I should say, and some of those complaints of visual issues, he did have a visual fields exam, which was normal. So we proceeded to surgery here, and it went well. It went a little bit better than expected, I would say, because I do think that I was able, based on the postoperative MRI, to remove all of this. And I'll go through, these are just some of the sequences, obviously, from the postoperative day 1 MRI. And the postoperative day 1 8 a.m. cortisol had come down to 16. So it was by no means subnormal, but a considerable reduction given what his preoperative levels were. And just the first set of questions I had, Dr. Laws, were, based on kind of what we did here, which the way I've handled these patients is I really want to see whether or not we've achieved remission up front. Though I know an alternative to that practice is immediately having the patient on hydrocortisone and then having an endocrinologist on an outpatient basis wean the hydrocortisone to determine whether or not you achieve remission. In this case, we kept the patient hospitalized for a few days. He actually hemodynamically was stable. He was just a little bit uncomfortable, a little bit lethargic, but he was not, he was not crashing or anything of that nature. The post-update cortisols on day 2 came down to 11, day 3 down to 7, and on day 4 down to 3. So we did get this subnormalization, if you will, of the cortisol, but it took a few days. Just a couple quick questions I had for you, kind of how you manage these patients, and how, I guess, for starters, do you like to do it this way, or are you inclined to have the patient started on hydrocortisone and then to determine on an outpatient basis whether or not you achieve remission? And how often are you seeing, and I imagine in this patient, because the cortisol was so incredibly high to begin with, it took a few days for it to kind of wash out, but how often are you seeing this happening over days, or the delayed response group even weeks into a month or more, which I've actually had a case recently where I thought I failed and it turned out it just was a delayed responder, I think in the 1 or 2 month range. So just was wondering your thoughts on that, because this is that very anxious zone where you're determining whether or not you actually accomplish the goals of surgery.
Good. Yeah, well, this is a difficult case, number one, because it's a pediatric case and they're notoriously larger tumors and more likely to be invasive. But that doesn't mean you shouldn't treat them just the same way. We don't give the patients any cortisol. Okay, their problem is they got too much cortisol, so we're not going to give them any cortisol after surgery. I do think that we see a stress response in some people that lingers into the postoperative day or 2 after surgery, sometimes more. So I check their cortisol every 8 hours for 4 or 5 days. And some will crash and plummet right away, and we're happy as can be. And some will take their time, like this one, and on day 4, we'll be down in subnormal levels, and you feel good about that. I don't like treating them as an outpatient or letting the endocrinologist do it, because they really don't understand about surgery and what we do and have patients recover. So, yeah, so I would have put this patient on low-dose cortisol, like 20/10 or 10/5, depends on how big he is. And then after 6 weeks or so, we stop the cortisol and see what he's doing on his own.
Yeah. Right.
And that's our routine. We have, we see the patients 1 week after surgery to check on their sodium primarily.
Mm-hmm.
We see them at 6 weeks for endocrine evaluation, because it takes that long for the normal gland to reestablish itself. And we do that often with the endocrinologist, but we are the ones who get the lab tests and then decide on whether to put them on a different daily dose of cortisone or none.
Right. They discharge them on physiologic dosing of hydrocortisone at 20 and 10, but he struggled for a few months with just not feeling well. And so they had to go up on that dose before they ultimately started.
That happens sometimes, but in
He was a
most
difficult
people,
patient for this endocrinologist. And it wasn't for lack of experience. It just was, I just think finding the sweet spot for him physiologically was difficult.
it sure looks good now.
So he was still on hydrocortisone at 20. She ultimately was able to get him back down to 20 and 10, kind of over a few months. Got an MRI. This is 4 months later.
Yeah,
He felt significantly better.
good job.
30 pounds, significant improvement in energy, ability to focus, apply himself in school, was thrilled. The MRI looked good. I read this basically myself as negative, but you could see here in the panel all the way to the left that maybe there's a suggestion there, just in the right paracellar region, of maybe some tumor. But it wasn't really that convincing. The radiologist, of course, we don't really lean on the radiologist in these cases, but was
Right. That was
but he was doing well clinically. So we didn't do anything here. And then in November, an MRI was repeated. So now we're getting to roughly 9-10 months after the original surgery. We could see that area now of question now has blossomed a bit.
Yep.
And his fatigue really started cropping up again. Otherwise, the weight loss had been preserved, very mild symptom recurrence, not nearly what he was before the surgery. So the endocrinologist went ahead. At this point, he actually transitioned to another endocrinologist for various reasons, but ran all these tests, and it turned out that the midnight salivaries were extremely high. The urinary cortisol was very high. His 8 a.m. cortisol and ACTH were not what they were preoperatively. It's 17 here, and it was
right.
yeah. So that's where we currently stand. The question being, I mean, to me, I think that this is recurrence, even though symptom-wise he's not as bad. The laboratory values are abnormal, but admittedly, he didn't get a midnight salivary 3 or 4 months after the surgery. He was, some of these tests were not done until there was a question of recurrence. But I think given the symptom improvement and now this, somewhat decline, and then you see this MRI, I'm inclined here to re-explore this region.
Yeah,
So,
I think you should.
yeah.
No.
Yeah.
Yeah. Otherwise, you'll be dicking around and you don't have any control over what that little thing is going to do. It may not cause a whole lot of mischief, but I think you can see it well, and where you've been there before.
Yeah.
And I think you have a pretty good chance. Now, I don't think he's a candidate for medical therapy.
Right.
Because it's just a miserable path for the patient and very expensive.
And also, I have a hard time kind of counseling about the endpoint with that therapy. Is it a life? Is it lifelong? Is it something, it's just, there's no real end game there, I feel, with medical therapy. But obviously, that's not in my hands. It's up to the endocrinologist.
Right.
Still.
Yeah.
But he's very young, and I think I'm hoping that it doesn't appear to me that it's in the cavernous. It looks like the carotid is distinct from it there. It's not really, but who knows? I'll see when we're there, but that's why I wanted to give him a chance as a young kid. I think it's fairly obvious to give this a re-exploration, and then I would consider, alternative approaches here.
I think the data from the Pittsburgh group and from Juan would be pretty convincing that there's going to be tumor in that wall of the cavernous sinus, especially since this is a, functional. But
I think so too. I certainly wouldn't do an adrenalectomy on him or either. I sort of reserve that for people who are really, really sick because you're going to get a cure.
Yeah, I mean, it seems like a re-exploration. I agree with everybody. It's reasonable here. You have a nice target, a young guy. I just, I always think kind of next steps. You go in there, you take this out, and we're sitting kind of back in this webinar 2 years from now with a little bit of recurrence there.
Right.
At what point do you say radiosurgery is appropriate? If this person were 65, would you recommend the re-resection, or would you say, you're not super symptomatic right now, We think there's part in the cavernous sinus, and while we could go back in, we may not get a cure. And, you know, we have the time, like you said, that interval of time to get a result with radiosurgery.
But even with radiosurgery and a youngster like that, young guy like that, his testosterone is at great risk, and he will really be pissed if things don't go well.
Absolutely. Absolutely. Well, appreciate the insights. Thank you.
Okay, thanks, Simon. Stephen?
Hey, let's see here. Can you see the video?
Yes.
All right. Let me move this out of the way. So this is a case I wanted to share, and I feel a little bit like I'm bringing coals to Newcastle or whatever with Dr. Laws here, who is technically my grandfather in pituitary surgery because of my mentorship from Danny Prevedello. But the case I'm going to show is one that we did recently with Dr. Prevedello, looking at especially trying to focus on extracapsular dissection, so and get a chance to really help these patients. This is a young woman who wanted to get pregnant, was having trouble with fertility issues, ultimately got referred to an endocrinologist. They were worried about PCOS and some other things, and they did a workup, and actually she had an elevated 24-hour free cortisol, 2 midnight cortisols elevated, and DEX suppression. So pretty clear exam. What was a little less clear is where the tumor was on her MRI. It looks like there may be something, let me go back to that, just a little hair, sorry. It looks like there may be something in the front of the gland here and kind of down low and possibly there, but the stalk is midline, not super clear. But we given that and the good biochemical workup, we wanted to go forward with surgery. I'm going to skip the ENT part I had left in when I made the video because they had complained I didn't show enough of that.
Yeah,
For this audience, we'll go right to the cellar opening here. And you can see a wide exposure. We do a midline dural opening and try to preserve the gland underneath there. You can see it's a little blurry, but you can see we see the gland, and then subdural dissection, just as Dr. Laws was talking about earlier. And you start to see initially a little tumor leaking there. We go on and open the cella widely, just like Dr. Zachariah showed with a wide exposure here. Dr. Prevedello likes to do it like a book. And then we can begin to see a thin rim of gland on the front here. And so we make an incision in that thin rim of gland to try to find that capsular space around the tumor. And we begin to gently dissect here and sharply open a little more of the gland around because this tumor actually looks bigger than it did on the MRI. These are a dissector, and we can begin to develop that plane starting inferiorly. We see a thin rim of gland there, and working our way around it. And one of the things that, as we use blunt instruments too, I think they help a lot to this ball dissector as part of the Angelina dissector set that Danny made. But we go around and can really begin to develop that plane. One of the tricks that I really wanted to kind of show in this video when I was making it and highlighting this is, as you develop the plane, sometimes it's difficult to visualize, especially when you're fighting with the endoscope. We don't have good forceps like you do with a microscope to spread and look unobstructed. And so one of the things you can do is start to put little pieces of gel foam in that space. Danny's taught me this, and you can actually put some fairly sizable ones once you've developed the plane to work your way around the back. And it's a twofold advantage here because it provides some hemostasis as you let them sit in there, and it also helps to deliver the tumor forward. And so I think actually it's similar to what Dr. Laws had talked about Oldfield discussing his technique for that supracellar ectopic Cushing's tumor there that we earlier today. But you can push these in from both sides, and you do one side, it comes a little further, then we go to the other side, and we can push the little pieces of gel foam into there, and it slowly is bringing this tumor out. Then if we go back, I think we'll go back here once we've kind of packed both sides and pushing into that extracapsular plane that we developed. And you see it can dry it up a bit. And now we can begin to explore and work our way posteriorly there. You can take the pledget out now after we've put the ones in on the other side, let it go, and you have a little more room in that plane to see. And using the dissector, then we can kind of try to find the back of the tumor. Once we do that, that's where he feels we can, then you'll see we bring in the ring curette to get around the back side here in just a moment. But this is helpful with a little tumor spilling there, but trying to work our way. And then he has this nice little ring we can use here that you kind of slide around on the back side to develop that final plane and work your way superiorly around the tumor. And you can see it slowly and carefully can begin to emerge from the cella. A few cells spilling here and there, but generally overall fairly extracapsular. I think this up close dissection is actually some of the hardest it has been for me to learn and with the endoscope. And unfortunately it was a little blurry on the scope here, but you can see the last couple pulls here to bring the whole tumor out, unblock. And there was a little adhesion that I think we come in a second here with some scissors and we'll cut. But we left it, you see one of the little gel foams coming out there that we had left from the other side. But those really help to open that plane up, especially that can be difficult. And here we cut the last little attachment of the tumor and then can remove it extracapsularly. So we reconstruct once we get it out here with, put a little piece of Duragen in there and get a nice picture like that when on these good days when they occasionally happen. That's a little hydrogen peroxide. I don't know, maybe that's voodoo at this point, but we decided to put a little bit in there, and that's the gel foam, Duragen inlay, and then a free mucosal graft we just lay on top of that. And we pack the sphenoid with some Duragen, but we don't use any glue or anything like that. This is zero gel. Other surgeons use Nasopore, and that will hold that free mucosal graft in place over that. Pathology showed some focal staining for ACTH throughout the tumor, showing that it was actually there. Also some Crookes changes, which I was wondering if Dr. Simon's case may have had some Crookes changes with that rapid recurrence in the patient there. And she had a crash on day 1, so I don't know if that's helpful or not, or it's kind of similar to what was done in the past there by Dr. Oldfield, but it was a cool case for us to have, and I thought you might enjoy as well.
Oh, that was beautiful. Really, really nice.
Thanks, Stephen. Yeah, great demonstration of some of the techniques and the cases for the smaller ones and how to really optimize them. So
one
nice
of
job.
the things we do that Danny does sometimes, you mentioned earlier, to scrape the walls with a pledget.
Yeah.
And he's used a Q-tip actually, and that works very well because you have some control and you can kind of spin it, and it has that adherent surface. That also works well for that.
Great. And any other
Nice.
questions?
Well, I've learned a lot.
Well, those
so
are
good about these things.
Well, I just want to say thank you again to Dr. Laws for his time and everything that he's put into this field thus far, and for everybody else who presented cases. It's been really, really educational, and I think this will be value to all the residents and students that watch this in the future. So thank you again. Everybody stay safe, and we'll see everybody back next month. Thanks.
Yeah, thank you.
Thank you.